Real quick, I wanted to really take an opportunity and talk to you about why it is that I do OLIF and in the context of single position. You've already seen presentations from Amir and Sean. Amir talking about putting in lateral screws and Sean talking about putting in putting in a 5-1 interbody. So a lot of us have seen this type of a patient who's come into our clinic. This particular patient, 68-year-old female, came in, had right lower extremity pain in an L4 radicular pattern. Oftentimes, this would be the type of presenting images that we would see. As you can see, she's got grade 1 spondy at 2 levels, but in particular, on this particular case, we're focusing on L3, L4. This may be a typical MRI that the patient may also present with. And as you can see, she's got pretty severe stenosis at L3 in addition to her spondylolisthesis at that particular level. So today we've heard a lot of discussions regards to how we can treat this patient. There are multiple options that are available to us as spine surgeons. We can do an ALIF, we can do a TLIF, we can do a DLIF or an XLIF, or we can do an OLIF. And so I'd like to really put everything together and talk to you about why it is that I particularly err on the side of doing an OLIF on this particular type of a patient. So number one, the goals for surgery and fixation as we're putting in posterior screws are pretty standard. Oftentimes we may choose to do an MIS procedure for placement of our screws. We have different options as far as imaging modalities that are available to us, O-arms, C-arms, et cetera. But the goal for these patients typically remain the same: restore alignment, stabilize the patient, and hopefully if they have any type of deformity, correct that deformity and deformity progression. So the real question is, can we improve upon these types of surgical procedures? As you know, fixation occurs for many different reasons. It could be because of trauma or iatrogenic reasons. But again, or also it could be because we're trying to correct a particular deformity. These various systems have evolved over many decades. Use of wires, screws, hooks, and dynamic implants, as we've seen today. There are various options that are available to us. And so my preference, not to bias this particular talk, but my preference is to use an MIS type system, typically a system that has towers that allow me to reduce the rods and also perform reductions using that same system. So in my particular OR, I use this particular system, which also allows me to utilize it using navigation. So this talk has a little bit of a bias towards navigation in terms of doing an OLIF style procedure using navigation, as well as the placement of those pedicle screws using navigation as well. And as you know, navigation has advanced over the years. We're hearing more and more about robotics as well, in addition to traditional use of intraoperative navigation such as the O-arm. So MIS, our goal, at least in most of our cases, at least in my case, is to minimize trauma to the surrounding soft tissue. In doing so, the hope is that we will decrease any inflammation in and around that soft tissue and allow our patients to be back to work, back at home, back active in the community, and hopefully having had surgery, that's a secondary thought for that patient. So what are our goals? So number one, limit the surgical corridor specifically to that particular operative site. We want to decrease any manipulation of the surrounding tissue. And so the question is, how do we do that? Well, we want to stay or respect the anatomical planes, the musculature and the neurovasculature. We want to minimize retraction time of the tissue and also minimize that retraction pressure. And I believe that the oblique lateral interbody fusion allows us to do that. Arguably, it is an MIS-style procedure. It limits surgical corridor to that specific area where we're doing our operation, minimize destruction of the surrounding tissue, and hopefully we can accomplish it reliably and safely for all of our patients. And so why is it muscle sparing? Well, as you know, one of our goals for doing lateral procedures is avoidance of the neural tissue, especially the femoral nerve. Oftentimes, we may utilize neuromonitoring in order to help us perform that procedure, but not always. What I found when performing the OLIF, neuromonitoring may actually be an option. I still use it in my OR, but very rarely does the neuromonitoring go off when we're doing this procedure. But again, what else are we trying to avoid? The most common area where we have disease that we're performing our operation are at L4-5 and L5-S1. And as you know, for our traditional XLIF procedure, oftentimes we may have challenges getting around the iliac crest. But we're also not only worrying about the patient, but we're also worried about us as surgeons. We want to ensure that whatever procedure that we do, we can do it reliably, safely, and for a long, long period of time. So ergonomics for the surgeon, I believe, is also important for these surgical procedures. And I would argue that performing an OLIF ergonomically for the surgeon is a lot better than doing an XLIF. And the other question is, how can we access all those levels? Can we do a procedure from L2 all the way down to S1? And I believe you can when you're performing an OLIF. So this procedure is not new. It actually is a kind of a twist of a retroperitoneal approach that has really progressed over the years. In this particular paper, they looked at 179 patients where they're performing an oblique procedure from L2 down to L5 using a minimally invasive approach, small surgical corridor, and it was an anti-Psoas procedure. And they discovered that it was able to be done very reliably with very few complications. And so what exactly are we talking about here? Well, the goal here is to really take advantage of this particular corridor. So it's a corridor between the psoas muscle and the veins, iliac artery and iliac vein. And Dr. Davis has performed a study which shows that this corridor is actually pretty reliable. It can be seen in most patients. It's usually anywhere from about a centimeter and a half to even up to 3 or 4 centimeters in as far as distance is concerned. So that's what we're going to utilize. We're going to go medial to the psoas muscle, but we're going to stay lateral to the vessels in order to be able to get into the disc space. And we're going to do it through a retroperitoneal approach. So what exactly are we trying to avoid? Well, all these neural structures, a lot of you may be familiar with Moro zones, and Moro was able to really map out on average where these neural structures would be located relative to those disc spaces. And the question is, how can we navigate either around or through? And again, we're talking about anti-psoas, so the preference here is to go anterior or not through the psoas muscle in order to get into the disc space at those various levels. And so again, Moro zones predicts that there's a higher degree of likelihood that you'll run into those neural structures in those higher zones, zone 4 and zone 3. So in order to be able to hopefully avoid those structures, if we go anterior to the psoas, then hopefully we can reliably get into that disc space without manipulating the muscle and also therefore manipulating those neural structures, including the femoral nerve. And so this is a great kind of a neurogram. It shows placement of a retractor. If you place a retractor in and through the psoas muscle, if you don't open the retractor, yes, you may be able to gain access to the disc space, but the minute you start opening the retractor, there is a chance that you may entrap the neural structures between the TP and the retractor itself. And more importantly, the question is, if you keep that retractor open for an extended period of time, will you have a higher degree of injury to those neural structures? So logically, the assumption here would be, well, why don't we try and just stay out of the psoas altogether and just go anterior to the psoas and still hopefully be able to get into that disc space. So with the oblique approach, the OLIF approach can be a great choice for the right patient. We're going to go anterior to the psoas. It can be also a great choice for the surgeon himself or herself. Typically, when we're doing the OLIF procedure, we're actually standing at the belly of the patient. We're not standing posterior to the patient. Here is a picture of Dr. Hines doing an OLIF procedure, as you can see on this picture on the right. So he's standing upright and erect. He's able to see into the disc space. He's not stooped over, bending over, cranking his neck in order to do the procedure. But unlike that, if you're doing a DLIF or an XLIF, oftentimes you're hunched over, you're standing on the posterior aspect of the patient, and oftentimes the longevity for the surgeon to do that procedure can be compromised. So again, with the OLIF, it's a more direct visualization procedure. You're looking into the incision, into the wound. You're able to see exactly what it is that you're working on at that particular disc space. Sean just really eloquently demonstrated how you can do an L5-S1 OLIF, and you're able to see the disc space, you're able to see the vasculature, and you're able to very reliably do your discectomy at that particular level. So again, this is kind of the typical view. You can see the disc space, the peritoneal contents are more medial, and they're being pulled down by this bottom retractor. And depending on the level at which you're operating on, typically you'll either have the psoas muscle or vessels that are more lateral being held by that other particular retractor. So the question is, where do we have access when we're doing an OLIF? Well, if we think of, or traditionally when we're doing ALIF style procedures, we have great access to L5-S1 all the way up to about L2-3. But the higher, the more cephalad we go, it becomes much more difficult and challenging. Oftentimes you have to mobilize the vessels much more in order to get access to those higher levels. With a DLIF or an XLIF procedure, again, you've got great access to those high levels, L1, 2, all the way up to about L3, 4. And if you're lucky, if they have a kind of a low-lying iliac crest, you'll have relatively good access to L4, 5. But I would argue that performing an OLIF, you'll have pretty good access to all of those levels, meaning you'll be able to get into L2, 3, all the way down to L5-S1. Now, the caveat here is if you're doing an L5-S1 procedure, for most surgeons, if they're doing it for the first time, the recommendation is to have an access surgeon assist you. But again, you can do it pretty reliably and pretty efficiently once you get a hang of it. So again, this is an evolution of a procedure. Russoli back in 2012 had described doing an anti-psoas approach. And over the years, we've just really kind of tweaked it a little bit, and it's been done very commonly up until today. So what are the pros and cons? Again, for an ALIF procedure, traditionally, I call it a two-position procedure. Oftentimes you're doing your anterior approach, and then you're going to flip the patient in order to put in your posterior pedicle screws. But what's great about the ALIF is you've got direct access to the disc space, you have excellent opportunity to perform distraction maneuvers, and an opportunity to put in large interbody implants. But again, oftentimes, if you're planning on putting in posterior screws, you're going to have to flip that patient in order to put in those screws on the posterior side. So, go ahead, Jeff. Can you hear me?
Yeah, we can hear you. No, it was just okay. one of the audience members couldn't see your slides, and I just said, go to speaker's view.
Oh, okay. Gotcha. So when we're talking about the TLIF or the PLIF, what's great about the TLIF or the PLIF is I call it a single position procedure, meaning patient remains in one single position. You can put in your inner bodies, you can put in your screws. The great thing about that is, again, you don't have to flip the patient, but oftentimes you end up putting in relatively small inner body or small implants. And you also oftentimes have to manipulate the vasculature in order to do that. So how do we take these two procedures and combine them? And again, I would argue in this particular instance, size does matter. The bigger the implant or the ability to place that implant along the apophyseal ring, I think has tremendous advantage, hopefully prevents subsidence and allows for a more reliable fusion. So can we take these two techniques, put them together? I think we certainly can with an OLIF. Single position procedure. It doesn't involve two positions. Hopefully it's just one position. Put in your inner body on the front side, put in your posterior screws on the posterior side without having to reposition that patient. And so we're taking the best of both worlds. What I had typically termed SOAPs, and when I say SOAPs, meaning take the OLIF, put it together, posterior cervical or posterior pedicle screws, and we're not talking about the traditional SOAPs in that, like the Young and the Restless, but SOAPs as in simultaneous placement of posterior pedicle screws in addition to putting in your OLIF inner body. So the synergy of these two, how is it done? You get all the advantages of an OLIF procedure from OLIF 2.5 to OLIF 5.1. Oftentimes it's done with use of navigation, so you can accurately place your screws. Don't have to necessarily utilize the C-arm or bring in the C-arm in order to determine where your inner body placements are going or where your posterior pedicle screws are going. And it also saves your staff that opportunity of getting extra X-ray exposure. So The other advantage is it can be a dual surgeon technique, meaning you have a surgeon on the front side putting in your anterior inner body, and you can have a surgeon on the posterior side doing or placing your posterior screws. So let's get back to this patient. Again, patient came in, had radic, had a spondy. Can you accurately put in an inner body at that particular level and posterior screws? And I would argue that you can. So the advantages for me in my OR is I can work simultaneously on the backside, putting in my posterior screws. Oftentimes I have my access surgeon working on the front side, gaining me access to placement of my inner body devices. So typical root setup, patient's lateral on the backside. Typically I have the anterior surgeon gaining or performing access. I have navigation coming in order to determine the patient's anatomy. Access surgeons working on the front side, and I'm putting in posterior screws on the back side. Now remember, as we're doing this, the key to doing this is placement of the patient in the lateral position. Always also be aware that you're able to rotate the patient in order to put in those posterior screws if need be. Again, as Amir had discussed before, oftentimes the most challenging screws are those bottom screws, but rotate the bed in order to do so. Typical patient positioning, patient is posterior, closer to the posterior edge of the bed. Oftentimes I'll put in bumps underneath the pelvis and also bump underneath the axilla. Sometimes an optional bump can be placed on the flank of the patient in order to ensure that the spine is in the same plane.
Is that just on a Jackson table? It's a simple Jackson table flat?
Just a simple flat table, nothing fancy. Now, if you have, and again, we want to make sure that everyone has the ability to perform this procedure without having to purchase any additional equipment. The key to the procedure, bring that patient to the posterior edge of that bed. That'll allow you adequate access to put in not only your what I call the ceilingward screws, but also the floorward screws, okay? Every now and again, I may place a bump on the belly side to really kind of cushion the patient as I'm securing the patient in place. Securing the patient is also going to be very key for this procedure. You don't have to break the bed. There's no breaking involved. Go ahead and tape the torso, tape the lower half of the patient to secure them appropriately. This is kind of the typical area of access for your anterior OLIF 2 to 5. You'll also ensure that you're taping the patient's lower extremity to ensure that if you are rotating that bed, that the lower extremity does not move. And this will be this is my typical taping technique. This is actually born from the XLIF or DLIF procedures where they really emphasize taping for the patient. And again, you're going to drape yourself very wide. On the posterior side, the drapes go low. On the front side, the drapes also go low, ensuring that you have adequate access to both the front and the back side for your OLIF 2.5. My landmark for the anterior portion, where I'm draping for the sterile zone, is the pubic symphysis. Ensure that you can feel it and don't drape above that pubic symphysis. And again, because I'm using navigation, we're going to put in a lateral reference frame. We have to be sure that that camera for your navigation is able to see both. Again, that's going to allow for placement of your posterior screws and also placement for your anterior inner body devices. Okay, so there's the camera, there's a reference frame, and there I am planning my trajectory for placement of my screws. And on this left picture, you can see my access surgeon is working on the anterior side in order to give me access to that L2 to S1 levels. Once we've done that, we utilize navigation and dilators in order to determine our trajectory through the pedicles into the vertebral bodies. It allows access for tapping if you so choose to tap. Again, I'm not using guide wires for this particular procedure because I'm very confident with the tower screws that we're using. And again, I'm using navigation to ensure that I have appropriate placement of all my posterior screws. So as you can see, the screws have gone in, but what I want to emphasize is remember that your anterior inner body needs to go in before you put in your rods. So again, if you're going to distract on the front side, go ahead and put in the inner body that's appropriate to you, and then go ahead and put in your rods and lock them down. Once the rods are in place, then you can come back, do your final spin, and break off the towers. So what are the pearls for what I call the soaps, or the OLIF and posterior perk screws? Again, ensure that you've draped sufficiently and kept everything in the sterile field so that you can do all your work adequately. Okay, again, go ahead and do your inner body work, place your inner body device on the front side, and then at the very end, you're going to put in your posterior screws and posterior rods. Okay, and then at that point, you can also go ahead and lock your screws into place. So screws are in. What's helpful also is to have two scrub techs and have your scrub team really go and run through the procedure ahead of time. That'll ensure that any hiccups for the procedure are minimized.
Thank you.
And also can be very advantageous if you have your access surgeon, if you're doing 5-1, to work with you simultaneously in order to complete the procedure. So let's wrap it up. At the end, everyone closes their incision. Oftentimes, I will tell you that I will actually leave the OR before my access surgeon does. It's just the way it happens with this. It's one of the first times we as surgeons have been able to do that, because usually our access surgeon leaves before we do. But on a good day, we can do this in just under 2 hours. Okay, so here, again, we've got placement of our screws, placement of our inner body. And then what's next? Well, hopefully, maybe we can use robotics in order to assist us. And maybe we could have the robot placing the screws on the back side, and we're doing and performing our inner body on the front side. Thank you.